Welcome to Netsmart Care Threads, a podcast where human services and post-acute leaders across the healthcare continuum come together to discuss industry trends, challenges, and opportunities. Listen as we uncover real stories about how to innovate and improve the quality of care for the communities we serve. Let's get into the show.
Okay, good morning, everyone. This is Mike Valentine, CEO of Netsmart. I'm excited to introduce a couple of people to focus on hospice care and palliative care today. First, I have Jim Parker, who's the editor of Hospice News. Jim spent 20 plus years in healthcare and policy. He's joining us today, I think, from Chicago. And he's a resident expert for policy in the hospice and palliative care industry. So, Jim, thank you for joining us today. And before we go too far, part of your bio has a mention of your descriptor being a swashbuckling feats of high adventure, bring a joyful tear to his salty eyes. So I haven't met many pirates from Chicago, but love to know the context of that one.
Thank you very much, Mike. I was honored to be asked to join this conversation. In regards to the bio, I enjoy pursuing new experiences. I want to experience as much of life as I possibly can. Even some of those pastimes can be mildly dangerous, but they, as I said, bring a tear of joy to my eye. In other words, there's kind of a method to the madness of my unconventional bio, is that people remember it.
Right.
So when I get in touch with them, hey, I have a few questions about this story, more are likely to remember who I am and perhaps be a little more responsive.
Well, perfect. Well, we appreciate you joining us today, and I will definitely remember you. Also very rememberable is Dawn Iddings. She's the general manager for us for our post-acute business here within Netsmart. She's been in healthcare for also 20 plus years in a variety of technology roles. And she leads the charge for us in all domains, including what we're going to go deep on today, the hospice and palliative care. So, Dawn, welcome and thanks for joining us.
Yes, glad to be here.
So today we're going to touch on palliative care. And just to set the context, Netsmart serves a lot of market community-based providers that play vital roles in the healthcare landscape. And over the last decade, what we've witnessed is more and more of a physician overlay into the markets that we serve. And so this integrated physician role, it makes sense. And it was accelerated by the pandemic as more and more services were pushed into the community or the home. The physicians followed the high acuity portions of that population. And so I think what we saw in the pandemic is a precursor to, and maybe an accelerant to what was already going on, which is more and more so the physician will play a key role in the service provision to all parts of care, whether it be behavioral health, care in the home, hospice, hospital in the home, SNFs, and things of that nature. So we're excited to go deep on the palliative front today. And, one of the things that happens with all of these models as they emerge and get a lot of momentum in the marketplace is if you, and Jim said this earlier, if you ask 12 people, you get 12 different definitions of what palliative care is. So we thought we would start there with Jim to give the context of, what is the core middle of the fairway definition of palliative care as it's defined and evolving today?
I would say, there are a lot of different models that exist for palliative care, and many of them have validity despite their differences. But I think that there are certain defining characteristics that are essential. One is that it has to be interdisciplinary. You have nurses, you have a physician, as you mentioned, social workers, perhaps other professionals, depending on the patient's needs. I also think the care has to be aligned with the patient's goals and wishes, and include that psychosocial piece as well as the physical symptom management. And I think perhaps the most crucial point that needs to come across is that palliative care is not the same thing as hospice, and patients should have access long before they reach the last 6 months of life.
Right. And Dawn, from your perspective, how do you see palliative care evolving, emerging in our client base relative to the technology needs as well?
Yeah, I would, as I think back 5 years ago, it was very much, kind of a small murmur of a conversation in our client base, right? Everyone kind of dabbling in that. We have a very large percentage of our clients, or we're kind of one of the market leaders in hospice. And to your point, Jim, palliative care is very interdisciplinary. And so who better to provide palliative care services than our hospice clients and agencies that are already set up in those care delivery models. And what I've seen over the past 5 years is tremendous growth. Some of my clients are actually predicting that their palliative care census is going to actually exceed what their delivery is in hospice. And for sure, I've also heard from them, it is a very important education point because they are a hospice. They have to do a lot of education with the patient to make sure that they understand there is a difference in palliative care because people are still, maybe not in the spectrum of ready to, accept hospice, but the value that these organizations are already set up to provide from palliative care delivery is there. That's kind of the model.
It's one of the interesting trends that we've also seen in our base is almost a rebranding around a more genericized descriptor of the continuum of services they can provide. So what used to be categorized as, hospice, now they're seeing that they can use those same skill sets across a broader continuum of services as those services evolve. And so they're rebranding around new names, and taking the hospice out of their name in many cases. And I think it's a very smart move because healthcare is this interesting beast that you grow up and you kind of align to reimbursement models. But as delivery models evolve, reshaping your organizations and your strategies and the reimbursement models that follow that, I think is a really bright idea. And we see that happening in our base. Jim, one of the things, so you think about the evolution and some people say, palliative care is reaching 5% of the potential audience that it could be reaching. So if you think forward and think about what the average provider needs to do in the way of preparing their organization from an infrastructure and a people perspective to support the potential growth opportunity that's there, what are the kinds of things that they should be thinking about today?
Providers are doing what they can with the resources at their disposal. Palliative care is generally not a moneymaker for these organizations. Some still support their programs through philanthropic donations. And so I think a key piece is continued education and advocacy to help, dispel some of the misconceptions and offer a wider range of knowledge about palliative care. I think more providers are looking into value-based contracts through programs like Medicare Advantage, ACOs, or some of the other alternative payment arrangements that are out there. They're also pursuing partnerships, I think, with other providers. One example is, they could work with a primary care provider and say, we'll provide this additional support to your patients and, maybe share in some of the cost savings that are generated through reduced hospitalizations and so forth. I think to achieve, any of those, relationships or build those partnerships, they need data and they need to have, a robust system for collecting and interpreting that data, whether it's their own quality and patient outcomes, whether it's their track record on reducing high acuity care, those ER visits, those hospitalizations. Those are the things that those partners, whether it's referral organizations, whether it's payers, whether it's other providers they can collaborate with, I think those are the things that they are looking for. I think that there is a learning curve for working in these programs, especially for hospices who have always been dependent primarily on the traditional Medicare benefit. A lot of them aren't as experienced with negotiating terms with payers and understanding, financial risk within those models. So I think that they need to definitely take steps to make sure that they're going in armed with all the information that they need. I also see a lot more investment in technology. Probably the most obvious example is telehealth, which allows them to have more touch points with patients with greater efficiency. But there's also systems like predictive analytics, remote patient monitoring to help patients in need to help identify patients in need of palliative care or respond more quickly to changes in their conditions.
Very good. Dawn, what about your perspective from a systems or solutions perspective? What are you hearing from our clients of the need today and how that may evolve in the near future?
Yeah, again, kind of going back a few years, I think as hospices started into, to palliative care delivery, there was, a big change in 2018 when CMS proposed a change in the payment rules for E&M services by physicians. It came along with it the mandate that they have certain technology platforms in play, particularly an ONC, Office of the National Coordinator, certified platform. What that means is platforms that have that status are able to do all the data quality tracking and reporting that are required to participate in the reimbursement program. So what that ended up resulting in our industry, particularly for hospices, is not having the right software technology underlying. We saw a lot of people moving to the ambulatory physician practice software to try to solve for that change in the rule, but that doesn't really work because, kind of as we've already talked about, hospice or palliative care delivery is interdisciplinary, right? And that is very much unlike those ambulatory softwares out there. So, that's one of the things that we did for our clients is to take our hospice platform, ONC certify it, so that our hospices could also run their interdisciplinary palliative programs and meet all the qualifications to participate in the reimbursement models. And that's been a huge request, really, for the whole industry, but certainly from our clients.
Right. And we see it as a major investment area for us as we continue to kind of follow the puck as it moves forward. So, Jim, you mentioned something, and I hear it a lot from our hospice and palliative care CEOs, which is we love the model. We believe in it. We believe it produces better outcomes. We think it's a great growth opportunity for our organization, but we're not making money on it today. And as you mentioned, many times they're aligned in the form of value-based care programs. And so what advice or what do you see as steps that providers can take to see success in these kinds of models? Or many of them have not contracted in value-based care models in the past. So this is all uncharted waters. So what advice would you give the providers today and as they look to enter some of these new agreements?
The one that I already alluded to is the data. You need to be able to demonstrate your value proposition to the payer in these value-based contracts. You also, need to be able to engage in these discussions as a collaborative process. It has to be a negotiation. You can't just accept the payer's terms off the bat. Just as hospice providers are often inexperienced working with private payers, payers are also inexperienced working with hospices. So kind of working out the care model that meets the payer's financial goals with the palliative care providers' model of care that would most benefit their patients. Hashing out those details is extremely important. So I think, the data is key. And as part of that is that education process also that we alluded to earlier. Many people do not know what palliative care is, whether that's, other clinicians in other fields, whether it's the payers or just the general public, some of whom may benefit from those services. I think providers working in value-based models need to understand, very in intricate detail their anticipated utilization, their related expenses, and where they can build in efficiencies and cost controls essential to maximizing those margins. I also think that they could benefit from some public advocacy, from working with lawmakers, with policymakers, with CMS, making their voice heard, commenting on proposed regulatory rules, writing letters, engaging with policymakers, even inviting like their local member of Congress or a state representative to visit their offices, maybe go ride along on some patient visits, because a lot of these value-based opportunities are very limited in terms of geography. Some of the demonstrations, are limited to certain markets, leaving some patients and providers out in the cold. And participation among the payers is also optional. A large contingent of Medicare Advantage plans, for example, do not offer the palliative care supplemental benefit. So I think that, there is a certain degree of advocacy that's needed to expand that access.
Yeah. I think your point on experimentation is a very good one, in that each one of these programs, this is new for everyone and evolving for everyone. And so I would say there's a lot of experimentation on the payers' part on how they think models should be played out in different regions. And I think that speaks to your point on the ability to negotiate. I think if you're starting from a point of both parties entering relatively uncharted waters, there's opportunity there to have more of a give and take around the definition and the boundaries. So I think that's a very good one. Dawn, anything you would add to that from what you're seeing in our client base?
Yeah, I would say that, my experience with talking with our clients and observation is they want to jump into these programs. And the CMMI demonstration projects that have, come down the pipe, like the seriously ill population program, which didn't get off the ground because of the pandemic, right? But primary care first, VBID, all of these models, really all of our clients want to participate in. And it very much goes to the point that you had made a couple times, Jim, and that is it's data. They have to have the underlying technology to collect the data, have the interoperability to be able to share that data. Participation in these kind of programs absolutely requires that your technology foundationally support them. But I think there's great willingness. They know they need to kind of for their future, and they want to. And it's really about the infrastructure and having the right skill sets in their organizations to do so.
Okay, one final question for both of you. If you take out the ball and look forward 5 years, what does palliative care look like 5 years from now? So how prevalent is it? What are the technology and infrastructure requirements, evolutions? What's your prediction for 5 years? I'll let you go first.
I think that the greatest success that I would like to see is that everyone who needs hospice and palliative care will be able to get it. And I think to get there will require attention to many of the issues we've been discussing: sustainable reimbursement, addressing the workforce shortage, greater public education, and working to dispel misconceptions around palliative care. I think that no one provider can solve those issues on their own, but I think improvement can be achieved by working collectively, by engaging with other stakeholders like payers, referral sources, and government to some extent. I think that the recognition is growing of palliative care and its potential to improve quality of life and reduce costs. The wheels are turning a little too slowly for my taste, considering the number of people right now who could benefit from those services. But I think that in time, we will get stronger reimbursement for palliative care. And in our system, the healthcare options that are available to us are largely defined by what somebody is willing to pay for. And I think as access to palliative care expands, as the results come in from these payment model demonstrations, there will be growing recognition of what palliative care can achieve. I also think that demand for hospice and palliative care will grow substantially, and the most successful organizations will be those who can, not only deliver, but demonstrate through their data that they can deliver high quality care while maximizing efficiency to ensure that they can do the work with the labor pool that is available to them.
Dawn, what are your thoughts?
Yeah, I really agree with everything that you said, Jim. And, ultimately, if we have that reimbursement model so that there can be full-scale participation in palliative care programs, the downstream effect to that also is that, many more patients and families will get that connection to hospice care as well, because they'll have that smoother transition. They will have gained that trust and understand what the value really is of hospice, so that, these short stays in hospice care really go away. That to me would be, if I dreamed into the crystal ball, what would happen, that would be what I would hope for. From a technology perspective, it's hard to predict 5 years out, as you know, Mike. We have to react to the shifting winds in a very fast pace, but we're already seeing it. More and more just primary care work, even being done by hospice organizations as they expand their role and think of themselves more as a care management organization, which means they need different types of tools to do population management on a whole different level. So that's kind of what I see kind of coming down the pike. It's really already here, and will just be all that much more mature as we get into it.
Great. Well, I wholeheartedly agree with both of you. And Dawn, I think your descriptor is perfect. It's a transitionary bridge that connects current care delivery models to hospice in a much smoother way, and fills an important gap for chronic conditions that are persistent. And I think the reimbursement model, I'm optimistic that the reimbursement model will get fixed. And so people will be rewarded for playing a role in this. And my prediction would be, I predict palliative care services will be 4 times the volume, will be 4 times the size as it is today. So we'll keep the video in the drawer and pull it out in 5 years and see how close we come. But great conversation today. Thank you both for taking the time to be a part of this. It's a really important part of the care continuum, and it's evolving very rapidly, and both of your perspectives are very well appreciated. So thank you again for taking the time, and we will circle back with a new topic shortly.
Thanks very much, Mike.
Yeah.
Great meeting you, Jim.
It's great meeting you, and good luck with the swashbuckling.
Thanks.
I love your articles, so I follow you.
I appreciate that.
Very much appreciate the work that you do.
Thanks so much. Thank you again for having me. I hope you both take care.
At Netsmart, we understand the challenges facing provider organizations. Our team will help you navigate changing value-based care models with solutions and services that make person-centered care a reality. We'll equip you with technology and services that provide holistic, real-time views of care histories that inform better decision-making and better outcomes. Visit us today at ntst.com. Netsmart, serving you so you can serve others. Thanks for listening to the Netsmart Care Threads podcast. Through collaboration and conversation, we can work together to make healthcare more connected than ever before and better support the communities we serve. To ensure you never miss an episode, please subscribe to the show in your favorite podcast player. If you use Apple Podcasts, we'd love for you to give us a quick rating for the show. Just tap the number of stars that you think the podcast deserves. Until next time.